I'm Pat St. Pierre, and thanks, Brett, for introducing me and giving me this opportunity to talk to everybody. So I'm at Desert Orthopedic Center, and as most of you probably already know, I do pretty much only shoulders now. And so we're going to talk about some of the newer things that are out in the shoulder world, talk about the things that I'm working on in particular, and we'll have a couple of times for breaks to ask a few questions, and we should have enough time at the end to field a lot of questions. So save the questions or go ahead and add them to the chat, and then we will follow that and we'll get to them as best we can. So I am part of the sports medicine program at Desert Orthopedic Center. I take care of the BMP Tennis Open when and if we can have it. So certainly last year in 2020, we didn't get to do it, and it's still up in the air for this year. But we also help with COD, Palm Springs Power, and Palm Desert High School. Okay. So first, I'd like to start off with talking about anatomy, so you can really understand the shoulder. And if you look on the left side, it's sawbones of the bones of the shoulder, and the shoulder joint is a ball and socket joint, but the socket is very shallow, and that's so we can get our hand everywhere in space. And for that to work and for us to use our shoulder and do everything that we want to do, we need to have muscles that control that shoulder and keep it working, and that's what the rotator cuff is. And there's four muscles of the rotator cuff. There's one in the front called the subscapularis, the one on top, which is the supraspinatus, and two in the back, which are the infraspinatus and teres minor. And inside the shoulder, so this is an arthroscopic view. I'm probing the labrum. So people hear about labral injuries. That's the long head of the biceps, and the bicep is often injured in the shoulder. In the front of the shoulder, there are some ligaments. So I'm putting my probe on the middle glenohumeral ligament, and now we can see the front rotator cuff muscle. So that's the subscapularis. So this is a pretty normal shoulder. This person had pathology up above the rotator cuff, so the inside is pretty good, and that's the insertion, and that's an area that often has an injury. This is the front labrum. So when we hear about labral tears and shoulder instability, when people tear their labrum, that's the injury, and that's the Bankart lesion that we talk about. And then the ball in the socket. So the cartilage should be nice and smooth and shiny, just like that, just like you see on the ends of chicken bones and turkey bones. This is now the top rotator cuff muscle. That's the supraspinatus. That's probably the rotator cuff muscle that's torn the most. And now as we come down the back, we're seeing the infraspinatus insertion on the back of the shoulder. Then we'll come back around, and we're going to look at the inferior labrum and the posterior labrum. So it's pretty good, the view that we get of the shoulder when we go in with an arthroscope, and we can take pictures and take care of everything arthroscopically. And what's really good about this is it's minimally invasive and not so much of a burden on the patient. And then we go into the subacromial space. So this is the space above the rotator cuff. So if you look at the pictures, the top bone is the acromion, which you can feel on the top of your shoulder. And underneath that is the bursa that we do most of our rotator cuff work in. And it's kind of a room that's inside the shoulder, and we'll be able to look at it. So here we are up above the rotator cuff. So what you're looking at on the bottom is the rotator cuff muscle over the top of the shoulder. And then this is the bursa, and it is very big. So if some of you may have had a subacromial injection or injection by us in the office, and that's where we inject it. We inject into that area in case there's inflammation. So he does have a little bit of inflammation of the rotator cuff. You can see how there's just a little bit more inflammation, but the rotator cuff is not torn. So again, those muscles help to secure it and to keep the ball in the socket. So when we raise our arm, the rotator cuff muscles are actually pulling down on the bone, keeping it centered inside the glenoid or the cup of the shoulder. And they also do rotation. That's where they get their name. So rotating in and out like this, it'll be something that the rotator cuff would do. Now, when we talk about things that go wrong, almost always in the shoulder, it involves three things. So there's pain, there's immobility or loss of motion, and then weakness. And these can come from traumatic events. It can also come from repetitive injury. And oftentimes people just don't know. They come in and say, you know, I woke up this day and maybe I, you know, was carrying luggage the day before, or I cleaned out the garage, or I did something, but it wasn't anything that I haven't done a million times, and I don't recall an injury. So it can often be just repetitive injury that normal activities that we do all the time. Then there can be numbness and radicular pain. And oftentimes when people start getting numbness, especially if it goes down to the hand, or what radicular pain means, shooting pain down the arm, that's not really coming from the shoulder, even though it may feel like it is. It's usually coming from the neck. So some of the things that I take care of mostly involve the rotator cuff. So the rotator cuff pathology is, number one is rotator cuff or impingement syndrome. So this is when people have inflammation of the tendon, so a tendinitis of the rotator cuff. They can have bursitis, and that's why we call it a syndrome, because it usually involves two or more things that are going on. As the injuries get worse, then they can develop rotator cuff tears. So you could have partial tears and then complete tears. And the problem with the rotator cuff is once that rotator cuff muscle is torn completely and it's pulled away from where it's supposed to be attached, then it's not going to go back unless we put it back surgically. So by doing exercises, all that happens is it pulls that muscle farther and farther away. So that's why most times when you have a big rotator cuff tear or something that's involved with interfering with your sports and the activities that you want to do, then we often have to fix that. Then the rotator cuff arthropathy, so that's when it gets really bad. So now you have a big and a massive tear of the rotator cuff, and then the shoulder doesn't function at all, or if it does, it's very, very weak. Then another set of shoulder injuries occurs with glenohumeral arthritis. So that shoulder arthritis, very similar to what we see in the knee and the hip and the foot, the ankle, and everywhere else in our bodies. So when arthritis occurs, the cartilage that's on the ends of the bone starts to wear away. And this can be totally separate and distinct from any rotator cuff pathology. So some people can have arthritis without any rotator cuff tears, but then people can also have rotator cuff tears along with their arthritis. Instability is something that usually occurs in younger people. So when people have shoulder dislocations, it's often a result of a sport injury or a fall or motor vehicle accident or skiing. And when people talk about a shoulder dislocation, that's very different than a shoulder separation. So shoulder separations are an injury to the AC joint, which is up on top of the shoulder. And a dislocation is when it dislocates completely. When it happens to a young person, it's very commonly will recur. So younger people that have 1 or 2 or 3 or more dislocations will often get surgery. My shoulder dislocated 40 times before I got mine fixed, but eventually had to get it fixed, and now it doesn't come out anymore. But in older patients, so people who are now in our age group in the 50s, 60s, and 70s and 80s, if you dislocate your shoulder, you're often going to have a rotator cuff tear as a part of it, and we're treating it as a rotator cuff injury. The bicep, bi means two, so there's 2 parts to the bicep, and just like we saw in the video, the bicep will go into the shoulder, and that's very commonly injured. In fact, the Europeans think it's the source of all major pain in the shoulder. And then the AC joint injuries, as I mentioned before, A means the acromion, which is the bone on top. C is for the clavicle. So this injury up on top, we can get arthritis, we can get shoulder separations. And then finally, another very common thing is the adhesive capsulitis or frozen shoulder. Although that's a very overused term, and often people will say, well, you got a frozen shoulder if they just have some loss of motion, which may occur with rotator cuff pathology. But a true frozen shoulder is an autoimmune thing that we see a lot in diabetics and people with thyroid disease, and their shoulder freezes up because the body is attacking the inside of the capsule. So like we talked about, we're going to talk about some of the newer things that are available to us and that we're working on. And the first one we're going to do is talk about this Biowic implant. And this is a scaffold that we have to help us with rotator cuff repair. Now, this is something I've been a part of the advisory team. So there are 6 of us across the country that have been involved in developing this, even from the beginning. And now this is it's in production. We're using it, and we've done some studies, and I'll talk about some of that before. So the challenge with rotator cuff repairs is there's a relatively high rate of failures, and in the literature, it can vary from 11% to 94%. So you say, well, most rotator cuffs heal and people do better. But if we critically look at the shoulder and we do MRIs after even successful rotator cuff repairs, sometimes they didn't heal completely. And we're trying to get them to heal in the maximum function and the best. And as you're seeing on the right, there's a big tear. So it's going to be very hard to get something like that to heal. And as you can see on the slide, if it's a small tear, most of them are going to heal. But as we get to those bigger tears, and even more so as we get to people who are further along in age, so you're much more likely not to have your rotator cuff heal when you're 80 than you are when you're 50 or 60. Now, these can come from different mechanisms of failure. So one is failure of mechanical features. So that would involve the anchors, the sutures, the different things that we use to repair a rotator cuff and sew it back down to the bone. And then the biological failures is it means that the tendon just didn't heal. And sometimes we can do everything right, but the tendon has atrophy, or the tendon's older, or the patient maybe smokes or has diabetes, and other factors that can interact with how well this is going to heal. And this is what we're going to see on the MRI over there on the right. So a lot of mechanical stuff has been worked on for years, and now we have great suture anchors. We figured out we use now suture tapes instead of single sutures, because the sutures would actually cut through the rotator cuff once the patient started working. So these tapes are a little bit stronger, they're broader, they capture more fibers and tend not to cut through the tendon anymore. And then there's vented anchors and ways that we could get blood and stem cells. So one way for tendons to heal better to bone is if we can get those cells that are going to promote healing and tendon healing. So that's what we're really focusing on with this study and these patches. So these patches have started out, and initially we had patches that would go on top of the rotator cuff, and then there were other anchors or other techniques like this crimson duvet, where one surgeon would put holes in the bone to try to encourage these cells to come out. But there was really no control over where those cells went or how they worked or anything else like that. So we were just kind of a hope and a prayer to see if it would work. And then the patches that we use on top are often very difficult to put in. So multiple anchors were necessary. It would take a lot more time. So our Biowic implant, this is an implant that we anchor into the bone, and then we have this patch. So you can see on the slide, there's a white patch, and that's really the scaffold. And we designed the scaffold to soak up blood and cells, and then it was a certain size that would induce the tendon to heal. And then the other really nice thing about it is it's a simple reproducible technique. So putting an anchor in is something that we all do as rotator cuff surgeons, and we pass the sutures, so nothing really changed except that this anchor was attached to the patch. I think I went too far. So as I mentioned before, the initial patches were kind of put on top, and that can help a little bit, but what the idea of this is that we would put the scaffold in between the bone and the tendon. So you can see on the top arthroscopic picture, the tendon is sewed down, and I don't think my pointer's working, but and it's in between. The arrow is pointing to the patch that's underneath the rotator cuff repair, and that's going to induce that tendon to heal inside the bone, as opposed to patches that were laid on top. So this is also something that absorbs. So it's a synthetic material, but will go away. So we don't have a foreign body that's going to stay inside the shoulder. The arthroscopic picture that you see to the right is one of my pictures. And here I've let down the pressure of the water that we use while we're doing a rotator cuff repair. And you can see the blood starting to come up out of the bone marrow and into that scaffold. And then once we sew the tendon down on top of it, it's going to compress that, and it's going to induce the healing to occur. And it's 80% porous, And again, the fiber diameter is specifically designed from numerous studies that have been done to induce this tendon healing. And that's pretty much what I talked about as well. So we want to have something that structurally and gives you the mechanical properties to induce that tendon healing, to get that new tissue to heal and to help the rotator cuff heal. So we started out with a sheep study. So even before this was launched, we wanted to test it in animals. And so I was involved in the sheep study as well. And we had controls and groups that we would do the rotator cuff repairs. So in the sheep, we would repair these tendons and use the scaffold that you see on the picture to the left. And then we would repair normal tendons of the rotator cuff and then compare the two. And there were a number of different ways that we would look at it in different regions that we would look to see how well that scaffold would help not only right where the scaffold was, but other places that it might be. And we found that there was a higher percentage of tissue integration at the tendon bone interface. We had greater new bone formation, which is what we want to see. We want that tendon growing into the bone. There were a higher number of perpendicular fibers that were growing into the tendon, and then a higher level of collagen that we want at that tendon interface. And then the implant was well tolerated without any bad events. So the body didn't reject this type of thing. And here you can see the first thing, the tissue is integrated. On the slide to the left, you can see in the bracket, there was some gapping that was there where the tendon didn't grow inside, and that was with our control group. And then on the right, you can see where it says tendon bone integration. That's where those tendons just meld right into the bone. And that's what normal fibers, they're called Sharpie's fibers. That's what they look like under a microscope for normal tendon healing. And that's what we were able to obtain. And then we also looked at how the body responded to it. So these were inflammation and Movin scores. So it's all this kind of complicated stuff, but we're looking to see if there were giant cells and different things that would occur. And there was no difference between our treatment group and our control group. And then we looked at the biomechanical testing, and our technique was very good. If you looked all the way on the left, the control one in the Biowic at 7 weeks, and then as it moved up to 12 weeks, our strength at 2,000 newtons was very, very strong, stronger than most of the other reported studies of rotator cuff repairs. And then when we compared this and we looked at it, and we looked at all the different factors and used this correlation analysis to show, and we had almost a perfect linear correlation between where we saw this improved tissue integration and new bone formation. We also saw greater strength with pullout on this rotator cuff. So then we felt pretty good about moving forward and starting a controlled study. And then because this is similar to previous rotator cuff repairs, we were able to release it. And then we started a study that now has been completed, but it was prospectively done. And we checked not only clinical scores, but also we had them go back to do an MRI to see how that healed. And it was for 24 months. Now everything has been completed, and all this study is now in review and is getting ready to be published. But again, we saw clinical improvement with our patients and also demonstration of tendon healing back to the bone. So this is a procedure. So here's a rotator cuff tear. This is one of my cases. So I'm using the shaver to debride the bone because we want to stimulate healing from that bone. And then here's all that goes in. So this is done, and this creates a path for our anchor, because the anchor that we're going to use it can be bioabsorbable, or it could also be plastic. And then there's also some that are just all sutures. So we're trying to use anchors and not leave metal in the shoulder as much anymore. So in fact, I don't use any metal anchors anymore, but we tap it just like you would a wood screw. And then here's our anchor. You can see it's plastic. And then inside that was our patch, or the Biowic, which is the component. So this goes in and it gets a nice secure tight fit inside the bone. And then if you notice the word Biowic, that is going to tell me which direction the patch is going to be when I take this off, because you can't really see the patch. So it is directionally oriented. So now the patch is on this side because I want that to lay over the bone. And then I'm going to pass the sutures through this rotator cuff. So that's our patch. And again, that's going to suck the bone elements and the stem cells out of the bone marrow inside. And then I'm going to pass those sutures through the rotator cuff and tie that down. I don't know if I want it. I'm going to, oh, here we go. So I'm going to grab the suture. So this is the technique that we do. So I have these suture passers and I'm going to pass the sutures through. Then we grab them. The other suture that you see there is from a biceps tenodesis that we did because there was injury to the biceps. Then we tie down these sutures and then compress that rotator cuff back down to the bone. But as you can see, as I tie this down, so this is like our fifth finger inside the shoulder, so I can tie the knot securely. I'm going to press down on this rotator cuff, and it's going to close that tendon over the top of the Biowick implant. And then we'll go through sequentially and tie down all of these different sutures. And these are really strong sutures that we can compress. So here you can see the blood's coming out, and then that wick, that Biowick implant is going to absorb that and hold that in position while we tie down all the rest of it. And then once we also let up on the water pressure, because you can see there's hardly any bleeding that we see. That's because I've filled this with water, and that's holding the pressure down. So here's our final repair. That looks really good. And then the Biowick is compressed underneath that. And we use a knotless technique that so we don't have knots on top. And this works very, very well. So this is very similar to most of the rotator cuff repairs we do. Now we have a few different options. Now there's some all suture anchors. We also have the PEEK. And PEEK is a very special plastic that's inert that the body doesn't react to. So another thing that often comes up in talks like this is using cells, so platelet-rich plasma or stem cells to do this. So platelet-rich plasma is something that we do at Desert Orthopedic Center, and it's and if you think about blood cells, there's really three major types. There's red blood cells that carry oxygen. There's white blood cells that fight infections, and then there's platelets. And platelets are cells that when you cut yourself, your body sends a bunch of platelets to form a clot, and that's what makes up that clot. And within those platelets, then there are growth factors and different things that are going to help things heal. So this has been around since 1987, when it was first done in open heart surgery, and now it's been used in many things. So ENT, dentistry, neurosurgery, it really just kind of took off. The problem with it is the insurance companies kind of caught wind of this, and they were paying for all this PRP. And so now they've really kind of stopped it to really prove that we have studies to do it. And even though we have studies now that show it, oftentimes this isn't covered by insurance and patients have to pay, unfortunately. But there are lots of studies that show that this can be effective for inflammation, osteoarthritis, tendon healing, and decrease the use of narcotics and different things as part of our healing process. So again, these alpha granules, they contain those growth factors, and the growth factors can be a number of different things, but this PDGF, which is a platelet-derived growth factor, stimulates cell reproduction, it produces healing within that, and then the other big one is the transforming growth factor, or TGF, which promotes the cell metabolism. Then there are several others. So the nice thing about these granules that it contains a lot of growth factors, and these things all have cellular responses. So they respond to the cell's stimulus to make them work, and also to the environment that they're in. So when we get these things and they're compressed between a tendon and a bone, the body tells them that they're supposed to create tendon and allow this healing, which is really pretty amazing. So our bodies are just incredible that we can take a tendon that's been torn off a bone, put it back down, get these growth factors, and the body tells it to heal. And so I'm still amazed at how well these things work in our body. And there's a whole process to how we create this. So we use a centrifuge to separate the cells, and we separate out the platelets, because if we inject just blood, then you're going to get a lot of red cells and a lot of white cells, which aren't going to be as helpful for the healing process. And then there's different ways of doing this and to inject it. And for orthopedics, we use it a lot for tennis elbow, rotator cuff repair, to augment ACL reconstructions and meniscal repairs, osteoarthritis in knees, other tendon injuries like Achilles tendon, patellar tendon injuries, and even partial ligament tears. So these can be very, very helpful. And there are clinical studies that have shown that. So Alan Mishra, who's up in San Francisco, was one of the first ones to show that the PRP was effective. This is another study in the hand journal showing that lateral epicondylitis, with 22 out of 28 were completely pain-free after the injection. And then Pierre is another one article that was published that showed that there was a significant improvement. And although these studies came out, especially for tendons around the elbows, a lot of there were other studies that showed that it wasn't as effective or that it was equivalent. And unfortunately, these are the studies that the insurance companies grab by the shoulders and say, okay, it shows that it's not work. And there were a lot of problems with some of these studies. There wasn't a control group, and there also isn't a control in the preparation. So obviously there's lots of medical companies and they're doing different things to these platelets, and they have to be a little bit different for patent infringement and all those types of things. So now we have a big variation of what's going on, and there really isn't a consensus yet or objective criteria to evaluate. So now we have to deal with insurance denial, but we can still do these at a fairly reasonable cost for people and get those things done if that's something they want to desire. Stem cells are another thing. So we hear a lot about stem cells, and stem cells are real sexy. You know, they're what's called pluripotential cells that are available in fat and bone marrow. And the idea is that these cells can manipulate and can change into either tendon or cartilage or whatever the body is telling it. The problem in the United States especially is we can't legally manipulate the stem cell. So if we had a way to tell the stem cell what we wanted it to become, that would really give us a big advantage. The opposition really comes from people that are looking that they think that this is the first step on a slippery slope. So if we start manipulating stem cells, then we can start creating life and doing those types of things. And some of these stem cells can be obtained from amniotic membranes and from placentas from childbirth. So there's a lot of opposition for that, but they're still being used. And there are surgeons that are happy to charge $5,000 to $10,000 or even more dollars for this, but they won't give you a guarantee. They just say, well, this could be a cool thing that'll work. And unfortunately, there isn't a lot of objective data to support that. And probably at the most, it's equivalent to some of the other treatment options that we have. So then you get a Biowulf biopsy, and then you end up going in. And especially if you're doing it for things that we know are not going to heal, then it's really not a good thing. But we need better studies, and we need to convince insurance companies that this is a good thing, and that we need to be able to do these for our patients. And I think that we need as a country to kind of decide where we're going to go with stem cells and research on these types of things. So what are other options? And I'm going to take a little sip of water here. Do we have some questions on what we've done so far in the chat room?
Nothing so far, Doctor.
Okay. So what can we do if the rotator cuff doesn't heal? And it's especially a problem in a young patient. And there are some other things. So one thing I wanted to share with people is doing what's called a superior capsular reconstruction. And when a rotator cuff is totally irreparable, and this is a big tear, in patients who are over 60, 65 years old, we can do the reverse shoulder, which we'll talk a little bit about in a few minutes. But when this happens in a younger person, we don't want to put a reverse shoulder in somebody who's 35 or 40 years old. So this is indicated for those types of patients without arthritis, younger patient who's active and needs their shoulder, but there's no way we can repair this rotator cuff. And this does happen. So we have grafts that and as we've gotten better as arthroscopic surgeons and better techniques, as you just saw with the Biowick and tying these knots and putting these anchors in, now we've developed into using these grafts for superior capsular reconstruction. And now we have knotless anchors that we can put in. We're not tying as much knots. And there's better ways of doing this to secure it. And we'll show you that in just a second. So Terry Mahata is a Japanese surgeon. He was the first one to come up with this. And this was his publication. Tai Lee is a biophysicist who's biomechanical engineer in Los Angeles. So they got together and really came up with this and showing that they could repair or substitute for the supraspinatus by doing this and then reduce the amount of elevation and make the shoulder much more functional. So when we do this, so sometimes you can have a tear like the one on the left, you can see some rotator cuff tissue on the left, and if it's mobilizable, we can repair that. But if it's all torn and it's all worn out, and if there's arthritis, we really can't. So we get in and we measure using the measuring devices to figure out where we're going to put this graft. You can see this is totally a bald head as opposed to the videos I showed earlier where this is all covered with a rotator cuff. And then we'll size and cut these grafts. We'll select where we're going to put our anchors, and it's got to be anchored on the inside at the top of the cup, which is the glenoid, and then also on the outside. So we pass our sutures through these grafts and we pass it through arthroscopically and tie it down to get it to repair. And it's really, I've been impressed with how well this works. It doesn't work for everybody, but I have patients who are now 5 and 6 years out from these supracapsular reconstructions who still have the ability to raise their arm and to be very functional. This will not give them the strength though. So as far as like putting a 10-pound bag of sugar up over their shoulder or up into a cabinet, it doesn't give them that kind of strength, but it gives them the ability to raise their arm and to do things that they're able to do. So this is kind of the soft tissue reverse shoulder, and it's an excellent option for younger patients, and the results are promising, and it doesn't burn any bridges. So if I can have a patient who's 40, 45 years old and I can do this on, and we buy them 15 to 20 years until they get the reverse shoulder, then we did them a huge favor, and it's a great way to treat this problem. A newer option, which is just coming out, is this in-space balloon. And so it's been designed to go in between the acromion and the humeral head when there's no rotator cuff. And this is what it looks like inside the shoulder. So you can expand this. And this was approved in Europe back in 2010. They worked out some of the kinks. We started a clinical trial in the United States about 3 or 4 years ago. That's just concluded, and we're hoping for a 2021 release for many people. So this, for someone who may be lower demand, who is, say, in their 80s, but they're not playing golf, not playing tennis, and doesn't want to go through, or doesn't have arthritis and doesn't want to go through the whole process of a reverse shoulder, this may be a nice, easier way to take care of this problem. Might also be indicated for someone who's really young. So the 40-year-old, instead of maybe doing the superior capsular reconstruction, if this works well, you can try this for a period of time. But eventually, the reverse shoulder provides much more strength and function of the shoulder. So what are the indications for the reverse shoulder arthroplasty? Well, in patients who have grossly deficient rotator cuffs and developing arthritis, as you see in that x-ray on your left, the ball is riding up, it's arthritic, and the rotator cuff is completely torn. And this was the first indication. So I went to Europe in 2003 to learn how to do these, and we started doing them in the United States in 2004. And it's amazing that the function and the results of these reverses have really improved. So now this is also, the reverse is the treatment of choice for failed joint replacement. So somebody who's had an anatomic shoulder placed, and now the rotator cuff doesn't function, we take that one out and we put a reverse in. For people that have fractures, so people who have fallen and shattered their shoulder, we do a reverse shoulder. That's going to work much, much better than any of the other techniques that we had prior to this. People with rheumatoid arthritis, massive rotator cuff tears, even if they don't have arthritis. Patients with what's called the B2 glenoid, or wear of the cup, because when the cup wears and we don't have a lot of bone there, then doing the old anatomic shoulder wouldn't work, because we couldn't fix that plastic cup very well to that native bone. And also the ball would still tend to ride out the back. So the reverse works great for that. And then now not even elderly patients, but even patients in their mid-60s with arthritis, I'll tend to do a reverse shoulder because then I don't have to worry about how well the rotator cuff heals. But one thing that's key is they must have a functional deltoid muscle to make this work. So here's a patient. So, my indication is when the patient can't raise his arm any higher than the tattooed lady can raise her leg, then it's time to do a reverse shoulder. And reverse shoulders have really changed the way that we take care of shoulders in the United States. So if you look back, all the way on the left of that is back in 2004 and up through 2012, it just the number of shoulder replacements started to mimic what we do for hips and knees, where there are much more shoulder or hips done in the United States than shoulders. And all of this is because of the reverse shoulder replacement. And then the hemiarthroplasty, or the partial shoulder, now is decreased in use. So we do this because they're working. Early results were much better than we expected. And when we looked at the anatomic shoulders, they're not always as good as expected, especially in patients in their 70s, 80s, and 90s, because we know their rotator cuff wouldn't heal, just like we've talked about. The front rotator cuff muscle, if that doesn't work, then that shoulder will not be able to function, and it won't be able to raise it up. And then we get more complications and more failures because of loosening. So, so the subscapularis, even if we do it, there are late failures, and oftentimes we need to switch people to a reverse. And there have been some great studies. This is a great study by April Armstrong, who's a friend who's at Penn State, and they did EMGs and ultrasounds and looked at these subscapularis. So these are very experienced shoulder surgeons repairing everything afterwards. And they found that half the patients had chronic denervation even when repaired. And often they were more commonly the subscapularis, which is probably the most important thing. And if that fails, then you don't have a functional shoulder joint, and it's an unconstrained system. So you see that ball and shoulder, that's what a total shoulder would look like. And if the rotator cuff's working perfectly, that will work great. But if it doesn't, then it'll pop out. So this is a patient who had a subscapularis repair, and actually this is my patient. And the shoulder came out and he couldn't raise his arm anymore. So we went back and converted that to a reverse shoulder, and now he's playing golf and doing everything. So here's an example of that bone wear that we were talking about. See the ball, the front of the shoulder is to the right, the back is to the left, and that's going out the back. So now most people will use the reverse shoulder to fix this and make it a more stable shoulder. And if we look at comparisons between the two, more and more we're seeing same amount of complications, same results with the reverse and the anatomic shoulder. When we looked at sports, so this is a group out of Hospital for Special Surgery in New York City, they had an 86% return to sports with the reverse, and only 65% with a hemiarthroplasty. Here's another one looking at ages. So reverses under 65 years old, very high survival rates, with 99% for 2 years and 91% at 5 years. And now I think that we're getting so good at these that most of these shoulders are going to last us 20, 25 years. And then this is another study out of the, I think it's the Cleveland Clinic, that showed that their return to activity was as good with the reverse, and they could get back to high demand activities. And that's really been my result. I see faster recovery with a reverse shoulder, equal return to golf, swimming, and no radiographic clinical failures at 10 years for these primary results, and more revisions of the anatomic shoulders that I've done than the reverses. And when I looked at a small cohort of 2 years between September 2011 to 13, we did 165 of these. They're constant scores, the dash scores. These are clinical scores that we looked at. All of those things improved, had a very low complication rate, and they were able to return with 78% returning to golf, swimming, tennis, and weightlifting. And the thing I love about it is it's a very reproducible surgery. So I can get these things, and those, putting the ball on the inside and securing it with those screws that you can see makes it very solid. And I really, knock on wood, have not had anyone fail with that type of fixation that didn't already have multiple revisions or bone loss, and were really tough cases to start with. And it's very reproducible, and you can put it back on. And if you talk to patients that have had this, not everybody, but most of them are back to doing a lot of things. We also talk about a rehab program. So we really focus on the rehab program so that you can do these exercises, and using TheraBand, using a wall, just to be able to do this. And for patients who may be on here that have seen me or had surgery, they know that we really focus on this. But this is what we can get back to. So this guy, he's got a reverse shoulder on the right side, and he's back to a 5 handicap. And this is him out of the sand trap. I think most people would be happy with that. And this guy's a little bit slower on them. So here he's lifting weights. He even took 2 dumbbells because 1 was not enough. Here he is doing flies. And he's back then was about 5 years out from his reverse, and now he's 10 years out. Patient's doing planks. And here's a gentleman. This is 1 year out from his surgery. And then on the right, he's 5 years out from the surgery. So you see that the results don't diminish with time. So he can still maintain active lifestyle and working out, as this gentleman has done. But as you can see here, he's doing push-ups for me. He wasn't tired, so he made me take the video from the other side as well. This gentleman, this is as far as range of motion. So he swims all the time. You can see the range of motion with his shoulder. So it's the right shoulder. I think it's a little delayed in using the Zoom video here, but you get the idea that he's got good motion. This gentleman's in the pool, and you can say, well, he's doing breaststroke, but how about doing freestyle and overhand crawl? He's going to go right back. So these are all with reverse shoulders, and they can be very functional as long as you do the rehabilitation program. And that's why we do this. This gentleman, you can go on our website, and a lot of these videos are on the website, and he's got a Bowflex program that he's gone back to just 6 months out from his replacement. And if you think about that reverse, he's got a reverse on the left side. He's able to do those flies. So I do anatomics when I have a patient who has got an arthritis, but he's got excellent rotator cuff function and minimal glenoid deformity, and usually somebody who's under 60 years old. And then I use the reverse for almost everything else. So now probably 90% of the surgeries that I do or more are the reverse shoulder arthroplasty, and we've been very happy with those results. And when I'm talking to other surgeons, because still 70% of shoulder replacements are done by surgeons doing less than 12 a year. Now, we don't have that problem here because there's primarily only 2 people in the Valley that do them. It's Dr. Saban and myself, and I'm still doing well over 200 a year, and he's doing over 100. So you're going to be able to go to somebody who does a lot of these replacements. And you want to be able to do something that you can rely on. And I think these surgeons who don't get to do as many should do the reverse, because it gives you equal results, and it's important to get really good at one arthroplasty. So another option is the Mako Robot. And this is something that I've been involved in. So the robot is what you see here, and it's been used in hips and knees. And I'm one of 5 surgeons across the world that are the primary consultants on designing this. Now, we're still a couple of years away because this takes a lot of planning, but what that robot is going to do, so when we as a surgeon will do the approach and we'll get in and expose the bone, but then the robot will then go in and make the cuts based on the CT scans that we had already planned. So as a surgeon, I would go and use a CT scan and would plan the surgery, and then we program that into the robot. And then when we get into the surgery, then we would register everything so that the robot knows where the body parts are. And then that tool will then go in and make the cuts or make the drill holes with exact accuracy, so that we know that it's exactly what we want to do. Now, oftentimes, I think surgeons who do a lot of these surgeries won't necessarily need the robot for something that's pretty routine. But when I get cases that are revisions or people with really severe bone loss, I can see this as being very, very helpful in the future. So here's a few more results. So this guy has had 2 reverses, and he's playing basketball and throwing a football. So for me, it's really, it's a no-brainer. If I can do the reverse, I'm going to do it that way. So that's we spent 45 minutes going through what I have ready to present. So success rate for the Biowick. That's what our clinical study showed, that there was, and we still don't know, the MRI results, which are probably going to be the most important. So I don't want to misquote something for that, but our clinical results have been over 90% success rates with this tendon healing. So if I can use a Biowick as a part of my rotator cuff repair, then I will. And but some of that's based on insurances too, because some insurances cover it, some insurances don't. And unfortunately, we're the victim of whatever insurance program that you may or may not have. I think the use of growth factors with the Biowick is a great idea. And I've gone to the company about doing more research and developing it. So I would even like, so if you put the Biowick in, and either you have it pre-impregnated into the Biowick, or we have injectables that we would inject into that, and then the scaffold holds on to that. I think that would be great. That's certainly something that I've been an advocate for, but we're just waiting for the companies to put up the money to do more research. And I think they're just waiting to see how the Biowick goes on. So right now, as far as the selling factor on it is, we're just telling patients that the growth factors and the different stem cells and stuff that are coming out of the humeral component is what's providing that. So partial shoulder replacements, that is what that hemiarthroplasty was. And there were a number of reasons why hemiarthroplasties were done pretty frequently 10 to 15 years ago. Number one is, especially with surgeons who didn't do a lot of these replacements, and there was a time when probably 80 to 90% were being done by people who did less than 10 to 15 a year. The exposure is very difficult. And if you can't get the cup exposed really well, and sometimes that's hard on people with bad arthritis, then the surgeon would say, well, I can't get there, I'm going to just do a partial replacement, and then would replace the head, but not replace the cup. And they worked, they helped, but they were not as good as doing a total shoulder replacement. So we know from a number of studies, whether it's an anatomic shoulder or a reverse shoulder, that a total shoulder will do better than a hemiarthroplasty. And although there was a time when the hemiarthroplasty was the treatment of choice for people without a rotator cuff, because the rotator cuff, if it's, as I discussed, the rotator cuff needs to keep that ball centered in the socket. Well, you can't put a plastic cup if the ball doesn't stay centered, because when the patient's moving their shoulder, it's going to loosen that and make it fail. So we used to do more hemiarthroplasties, but I can tell you, I haven't done a partial shoulder replacement in at least 8 years. I think I did a couple when I first got here 10 to 12 years ago, but I haven't done any since. The next question is, what procedure do you recommend when the rotator cuff is 60% separated underneath instead of torn on top? So that is, that's an MRI finding that you may get. So you get an MRI, you've got shoulder pain, and the MRI shows that there's what's called an articular surface. So if we have a rotator cuff like this, and it's over the top of the joint, so where it inserts on the bone here is where the tear is, but the top is still intact. And that occurs, and sometimes it's because of what we call internal impingement. So if that occurs, sometimes patients will get better with just doing a debridement, or really the first thing we do is do an injection, do rehab, and see if that'll get better. There are times when if we go in and the patient just hasn't gotten better. So the indication to operate on that person is that they haven't gotten better with rest, injections, physical therapy, and they can't get back to their activity. They can't get back to doing, the sports that they want to do, or racket sports, or playing golf, or they can't sleep at night because every time they roll on that shoulder, then they get pain. Then we'll operate on it. And this is actually a procedure that I've done a Biowic on. So you can go in and place the Biowic on the undersurface of it, sew down the rest of the rotator cuff on top of that, and then that will heal. Or you can do a rotator cuff repair without doing a Biowic. There's a little bit of argument among the shoulder surgeons about what technique's better, because sometimes you'll try to leave that top portion intact and just do the repair and then sew things down. Or some people will say it's better to just go ahead and complete the tear and sew it down. So that's controversial, and probably up to the surgeon to decide what's the best thing. If it's 60%, maybe it's better to try to leave the top part intact and do the repair. If it's 90%, I think you're better off just completing it and just repairing it as you would any other rotator cuff repair. How well are these procedures covered by Medicare? So rotator cuff repairs, shoulder replacements, those are all covered by Medicare. Now, some people have different Medicare plans. So there are some, like the Medicare Advantage plan, and there are some other plans that will do supplements. And I'm not so sure they really help do the whole thing. So if you have straight Medicare and you're covered for all the different components of it, then usually these things are covered completely, because we at Desert Orthopedic Center, we accept Medicare. Sometimes if you have just the plain straight Medicare, and say you decide, well, I really like that concept of doing the Biowic, then that might be something that would be charged as a separate thing. But most rotator cuff repairs are paid for fully by insurances. What happens to the Biowic patch over time? And it does eventually dissolve. So it's a synthetic made patch, but it will be absorbed by the body. And usually by 3 to 4 months after the surgery, it's gone because it's already done its job. It takes 12 to 16 weeks for a tendon to grow into the bone. And that's really all that I want that patch there for. And if that, in fact, we think the patch actually contributes to faster healing. So if we get that to heal faster, then if it goes away, that's even better. The site to show these shoulder exercises, that's a great question. So if you go to desertortho.com, so that's our website for Desert Orthopedic Center, and there'll be a tab across the top that has providers. And then you click on that, and then you'll see all the different providers that we have within Desert Orthopedic Center. If you go and click on my name, then you'll go to my page. And within that page, there's some articles that I've written, some other things, some testimonies from patients. And then we also have some videos of people doing the home exercise program. So that's a great way to do that. And then if you do come in for surgery, then we'll also go over that with you. I have a great physician's assistant named Jim Roselle, and he helps me with seeing patients, and both of us will go over all those exercises and different things to different stages for your repairs. And then there's the question about frozen shoulders. As it is, so a true adhesive capsulitis, where we see the inflammation, and it is an autoimmune response. That's why we see it so much in diabetics and in people with certain thyroid diseases, because diabetes is an autoimmune response. Your body is attacking the cells inside the pancreas, and it stops creating insulin. And thyroid disease often works the same way. So we see true frozen shoulders a lot with those types of patients. And sometimes a frozen shoulder will just occur out of the blue. Sometimes it's trauma driven. So someone will hurt their shoulder and develop what would be a normal rotator cuff syndrome for everybody else. but for them, they developed this frozen shoulder. And when you get a true frozen shoulder, it's not that, you know, you're limited. So people will say, so if I have a rotator cuff problem, I may only be able to get up to here as opposed to getting all the way up to here. True frozen shoulders, they're stuck here and they can't move their arm out to the side, and they certainly can't go behind their back. So that is an autoimmune reaction. And sometimes in the initial time or initial phase where the frozen shoulder is really more painful than frozen, we often do injections, and we can do corticosteroid injections. And there's a slow release corticosteroid injection that looks to be very promising for frozen shoulders, that will just slowly release the cortisone. So people with diabetes, it doesn't raise your blood sugars, and it really works really works well for that. Yeah, someone mentions their Kaiser copay for the reverse shoulder, it was $200. Yeah, whatever insurance, all these insurance plans are different. They have different things. So I'm not an insurance expert. And whatever the copays that are a part of it, and I just can't, it might be. So when we submit for surgeries, our scheduler will go ahead and submit to your insurance company so that you'll be able to find out, or you can, you know, call them up and find out what their is. Okay, here's one that a patient of mine who shared that he did, so 7 months after his surgery, he played 18 holes of golf and he was totally pain-free. Tennis is 2 weeks away. That's good to hear, Arnold. I hope you do well with playing tennis. And then typical recovery room. So that kind of ties into that. So the recovery time from a reverse shoulder, we keep people in a sling for 4 weeks, but they start doing their exercises immediately after their surgery. So usually we give them some really basic exercises for the first 5 days. We use a plastic bandage that allows you to take a shower. So you bathe the next day. Now, these surgeries, especially with COVID, we're letting people go home the same day of surgery, and it's actually worked very, very well this year, the patients that have gone home immediately, because our anesthesiologists will block the nerves coming out of your neck so you don't feel any pain during surgery. You wake up without any pain, then you can go home with any pain. And then when the block wears off, which is usually the next day, then you're at home, you're icing your shoulder, you've had something to eat or drink, so you can tolerate the pain pills. I don't know if I had time to get into narcotics, but I hate narcotics. As some of you may, I had just had both my hips replaced. I didn't take any narcotics. They don't work. They go to your brain, they give your brain a reward that distracts you from the pain. But we used to think that it did help patients get through. But what's happened is that our brains love that reward. And even though the patients are often constipated and feel nauseous and they don't really like the feeling, the brain loves the narcotic and very quickly figures out that to get the narcotic, the patient has to have pain, and it sets up chronic pain in the brain that mimics the pain that they're having, so they never know when the pain goes away. So that's how we created a nation addicted to these things. So most of our patients take less than 10, and usually it's for the first day or two after the block is worn off, and then we transition right to extra strength Tylenol. And I'd say, you know, most people, when we see them 4 or 5 days later after surgery, they're off of narcotics, they're on Tylenol, and they're doing just fine. Further recovery, though, as you go on. So my golfers are chipping and putting usually at 3 to 4 months, and full golf at 5 to 6 months. Results are different for everybody, though. It's very hard to standardize. There are some people that really work hard at their exercises. There are some people that have more problems. You know, they had a bigger rotator cuff tear. And certainly one thing that I certainly see is that patients who have not used their shoulder for a long time, so it's been a year or two of just putting up with severe pain, they're avoiding it, they're not using their shoulder, it takes them longer to recover because all their muscles have atrophied and haven't done as well. So I think that's it. If there's no other questions, actually we're right at 5 o'clock. So thank you all for your attention. I see we had a pretty good crowd, and if you do have problems like this, then come and see us at Desert Orthopedic Center. More than happy to see you and take care of you and take care of whatever the specific problem that you have.